or full screen?
Sir, I have done full screen, sir.
Yeah. All right. Just give me a minute, ma.
Yes.
Sir, I have done full screen, sir.
Yeah. You are good to go, ma. Just wait a minute. I'm just setting the YouTube. All right. It's not 8-1. Good evening, friends. Today we have two important examination cases. Been quite some time we discussed foregut case. So achalasia of the cardia is either a long question or short question. Movement disorder or motility disorder of the esophagus will be a certain question for you in the vivas or in the theory examination part of it. And the interpretation of endoscopic findings, interpretation of manometry and pH definitely is important. And the surgical choice and the endoscopic choice are the core important values. Thank you, Hemant sir, for kindly permitting your resident, Dr. Siddhant, for presenting this important case for discussion. Then we have Dr. Surya. Surya is kindly contributed by Professor Saravanan sir. Saravanan sir is professor and head of the department at Madurai Medical College. And Surya will be presenting a case of varicose veins. Been quite some time we presented varicose vein. He is from Professor Ganga Madam's unit, and we'll have the achalasia of the cardia thing first, and then we'll have the other thing second. We have Professor Narendra Gupta sir joining us. He's a professor of surgery from Hindi Institute of Medical Sciences at Sitapur. And we have Professor Krit Parmar. Again, he's been with us for quite some time on a regular basis. He is from Ahmedabad. So all others are expected to join us over YouTube also. So with that few words, I hand over this to the faculty. Dr. Siddhant, please introduce yourself, your unit chief and head of the department, and start your presentation. You will be running through the history part of it without stopping. And then the professors may sum up and then come back to each one of the slides to take it further on step-by-step basis. Same way, the clinical examination will run without halting. And then we have another half an hour left for discussing the management part of it, investigation and treatment, and what are the potential complications you need to manage. That's how the system works here. And all the faculty have been with us earlier for the discussion. So it is for you or the instructions. And at some point of time, if you feel you are not sure about the answer, please tell so. This system works like a teaching session. Like if you find difficult, please tell. The faculty will be able to give the answer so that we move on to the next area. And I wish both the students good luck. And then I request Dr. Siddhant and Hemant to start the first presentation. Good luck to you, Dr. Siddhant.
Thank you, sir. My name is Dr. Siddhan. I am junior resident in Himalayan Institute of Medical Sciences. My unit head and moderator is Dr. Professor Hemant Kumar Nautiyal, sir, Professor and HOD, Department of General Surgery, Himalayan Institute of Medical Sciences, Dehradun. I am presenting a case of a 24-year-old male student, resident of Nainital, presented with the chief complaint of difficulty in swallowing for the past 12 years, regurgitation of meal for the past 10 years, on and off weight loss for the past 9 years. Patient presented to him OPD with complaints of difficulty in swallowing for the past 12 years, which was insidious in onset, gradually progressive, initially with liquids, later progressed to solids, as well as associated with regurgitation of food 30 to 60 minutes after meals, which was non-bilious, non-blood stains, and non-foul smelling. It was also associated with dyspepsia, which was not relieved after taking PPIs. Patient also complained of on and off weight loss in the past 12 years, history of repeated URTIs. There was no history of fever, no history of pain during swallowing, no history of abdominal or chest pain, no history of loss of appetite, no history of skin changes, no history of radiation, no history of hemoptysis, no history of hoarseness of voice, no history of corrosive intake, and no history of international travel. Medical history, there was no history of diabetes mellitus, hypertension, COPD, or tuberculosis. There was no history of any previous surgeries. Personal history, patient was a vegetarian by diet, non-smoker, occasionally consumes alcohol in the past 4 years, No history of any substance abuse. Normal bowel and bladder habits. Patient regularly chews gums, mints due to bad breath. There was no history of any allergies. No family history of any malignancies. To summarize my case, a 24-year-old male presented with complaints of progressive dysphagia for the past 12 years, initially for liquids, later progressed to solids, associated with regurgitation of food and dyspepsia, which was not relieved on taking PPIs, with history of on and off weight loss and repeated URTIs. My provisional diagnosis is esophageal motility disorder, likely Acahalasia cardia.
Yeah, Dr. Siddhant,
Yes, sir.
let's go to your first slide, please. History of difficulty in swallowing for past 12 years. So he's 24, so since 12 years of age.
Sorry, sir, I didn't get you.
You said history of swallowing, difficulty in swallowing since past 12 years,
Yes, sir.
and he's 24 years of age.
Yes, sir. Yes, sir. He was a child since he started.
Okay. So let's go to your next slide now. So it started when he was 12 years old and has
Yes,
progressed gradually. To
yes,
what?
sir.
What progressive? To what progress? We have not been able to see any progress.
Sir,
Can he
patient
eat? Can he not eat?
Hello.
Hello, can you
Sir,
hear
am I
me?
audible? Yes, sir. Yes, sir.
Right. So what is, I mean, how have you said it's progressive? How by
Sir,
history
the
have you said it's
yes, sir. Sir, the patient initially had difficulty in swallowing liquids, which later progressed to solids.
how how much later?
Sir, in the past 2 to 3 years.
So
Sir,
for
in
10
the next 2 to 3 years,
10 years,
meaning
for
by the
10
age of
for 10
50.
so for 10 years he's not been able to take liquids.
Yes, sir. He said he has not been able to swallow any solid foods for the past 10 years.
So no, I can't understand. How much can he drink a glass of water?
Yes, sir. He can take a glass of water, but he says it is, sir, it is uncomfortable.
Uncomfortable in what? What does he get pain? Does he get
Sir, no
chokes? Does
pain,
it
but
come out?
sir, if the patient, it is, sir, discomfort. It provides discomfort to the
Dr.
patient.
Siddhant, when you say
Yes,
progressive, you have to say that he could take a glass of 5 glasses of water, a glass of water initially. Now he
yes, sir.
is unable to take half a glass. If he was just, he could take half his meal or two chapatis. Now he's not being able to take one chapati.
Yes, yes,
Your
sir.
history
Yes.
is not telling me how has it progressed.
Sir, initially, sir, it was, sir, for liquids. That then, sir, it became for solids. But initially, he was able to take a good amount of liquids and solids. But later on, it decreased gradually. And for the
So
past 5 to 7 years, the patient has been it has been non-progressive.
okay,
So,
we'll come to
Dr.
that.
Siddhant, if I can ask you,
Yes,
so do you know any grading system for dysphagia? When you say
sir.
dysphagia, it is an important clinical history.
Yes, sir.
So, how do you grade dysphagia? Because when you talk about dysphagia, you've said about solids, liquids, etc. So, do you know of any grading system that you're aware of?
Sir, grades of dysphagia, sir. Uh, Sir, 4 clinical grades are present, sir. Yes, sir.
Okay, so can you tell what they are?
Sir, grade 1, grade 2, grade 3, and grade 4, sir. Sir, grade 1 is mild. Sir, grade 1 is mild for, sir, difficulty in swallowing solid, sir. And grade 2 is moderate, sir, with, sir, porridge like, sir, and semi solid, sir. uh, Grade 3 is difficulty with liquid, sir. And sir, grade 4 is unable to even swallow his own saliva.
Okay, so there are different grading systems, but
Yes.
I think the the standard one has got 6 grades. It's by Suguhara. But I think what you're saying is roughly okay. So basically for solids, and then to liquids, and then to
Yes.
nothing else. So
Yes.
you should be able to grade dysphagia, and it's very important. And that's what Sir was asking. Uh, you say progressive. So how it progresses is the question. Now, you said that it is for liquids and not for solids. Is that a common feature for a progressive dysphagia?
Sir, mostly, sir, initially, sir, patient is, if having, usually he has first for solids, then for liquid, sir. That is, sir, progressive. Sir, am I audible?
Yeah. So progressive dysphagia generally is from solids, then goes on to liquids.
Yes, sir.
Whereas in this history, you have got the other way around.
Yes,
So that is a feature of what? Where you get
sir.
more for liquids than
Sir,
for
more for
solids.
liquids and then for solids, sir. This is, sir, classical, sir, for Acahalasia, sir.
And can you explain why that is so?
Sir,
Why do
sir, due to, sir, sir, due to hyper contractility of the lower esophageal sphincter, no liquids are unable to pass, but due a solid bolus due with pushing can pass through.
by gravity, I guess.
Yes, sir, by
So the
gravity.
solids, they may go down with gravity, but
Yes, sir.
liquid is a bit more difficult.
Yes, sir.
Okay, just go on to your next slide. So
I just want to ask one question.
yes, sir, please, yeah.
Yes. What is difference between reflux and regurgitation?
Sir, reflux, sir. Reflux is from, sir, of the stomach content, sir.
So any kind of mechanical obstruction, and then the food comes back, that is regurgitation. There is
Yes,
some kind of obstruction,
yes,
either
sir.
mass, it can be Acahalasia cardia, anything,
Yes, sir.
right? But whenever there is a reflux, the sphincter is relaxed.
Yes, sir.
It is a reflux. So that is the basic difference. What is
Yes,
odynophilia?
sir. That is pain during swallowing,
What are the causes of that?
sir. Odynophagia, sir. Sir, due to, sir, laryngeal, uh, some laryngeal pher- causes, sir, pharyngitis, sir.
Can it occur with Barrett's esophagus?
Uh, yes, sir. Barrett's esophagus. Yes, sir.
You have written on and off weight loss. What do you mean by that?
Sir, the patient in between has intermittent episodes of weight loss, and then he regains the weight uh, due to, sir, regurgitation and all. He used to stop taking food, and which caused the weight loss. But due to, sir, the due to the sir, appetite, sir, he again taking food, and which led to a regain of the weight. Sir, he said he used to lose 2 to 3 kgs, and then used to regain them in a month or two.
So how you can explain that?
Uh, Sir, it was due to, sir, the regurgitation and the discomfort due to eating food, sir, that the patient loses weight. The,
What about the appetite of the patient?
sir, the appetite is normal, sir. There was no loss of appetite, sir. But
So
during the
this,
weight loss periods, he had increased appetite, sir.
so any patients of regurgitation, you have to differentiate basically in your exams. It might be asked whether it is what is the cause, whether it is malignancy or not.
Yes,
So
sir.
in case of Acahalasia cardia, you might have to ask history whether the patient has undergone any endoscopic management or not.
Yes,
Most
sir.
of the time, patient might have been going the esophageal dilatation, and then progressively patient might be able to take the food.
Yes,
But depending upon the length of the esophagus involved, patient can again develop stricture or patient can again develop echalasia. That might be the cause. And initially, patient is able to take the solids. It creates by the gravity, as sir rightly said, with the help of gravity, that food will go down.
yes, sir.
So in patient can regain weight in between. So
Yes, sir.
whenever in exam any history, whenever you say, you need to be very specific if there is any history of weight loss or not. Since starting of the patient symptoms in these 12 years, whether the patient has gained the weight or patient has lost the weight. If the patient has lost the weight, how much weight patient has lost?
Yes, sir.
So in your patient, what is the case? Has patient gained the weight or lost the weight?
Sir, the patient has he was a 12-year-old boy. By that standard, sir, the patient has not lost or gained weight as per se. He's when he was operated, he was of 42 kgs, sir.
So you said that there is repeated history of URTI. What do you mean by that? What actually happens?
Sir, the patient said that he was admitted. He had multiple episodes of an upper respiratory tract infection and sometimes even lower respiratory tract infections. He was even admitted twice for the same.
So what is the pathophysiology? What occurs to the patient?
Sir, due to regurgitation of food, there is micro aspiration, sir.
So that micro aspiration, initially what changes occurs in the pharynx?
Sir,
There
pharynx.
is very classical granular pharyngitis.
Yes,
That might be very painful. Granular pharyngitis that occurs, and yes, you say that micro aspirations and even bigger aspirations can also occur.
yes, sir.
That can it can create lower respiratory tract infections also.
Yes, sir. Yes,
Okay, you can go to the next slide.
yes,
So you've given a long history of negative history, which is all
yes,
very, very important. Um, so you need to know why you give this history, negative history.
yes.
So you want to quickly go through that. Why do you think history of fever is important in dysphagia?
Sir, sir, when the patient was admitted, we have to know if he's having a underlying lung infection or, sir, like bronchiectasis, lung abscess, and pneumonia or anything, sir.
Okay, so as a complication, respiratory
Yes,
complication you're thinking
yes,
of.
yes, sir.
Okay, we've discussed about pain during swallowing, which is odynophagia.
Yes, sir.
Why is chest pain important?
Sir, it is one of those differentials for, sir, Acahalasia, sir, nutcracker esophagus, sir, jackhammer esophagus. They have a myocardial infarction like chest pain.
Okay, so in classical achalasia, can you get chest pain?
Yes, sir.
Yeah, so it is not only in the other forms, but even in classical achalasia, you can get chest pain.
Yes.
And in fact, there is a scoring system, no, for achalasia. Are you aware of any scoring system?
Sir, sir, Acahalasia, sir, no, sir.
Okay, so it's called Eckhart score. And in fact, chest pain is one of the uh, features or one of the components of that scoring system. So it is very important to ask for chest pain.
Yes, sir. Yes, sir.
Okay. Why did you say skin changes?
Sir, achalasia, secondary causes of achalasia, sir, and visual motility disorders. One of those is, sir, scleroderma.
Okay, good. And you've talked about hemoptysis again, which is probably respiratory problem.
Yes, sir. Yes, sir.
Why are you talking about hoarseness of voice here?
Sir, if sir, if the it is due to a mechanical obstruction, the symptoms, they may also cause hoarseness of voice, due to mass effect, sir, by involving the recurrent laryngeal nerve.
So you're talking about malignant dysphagia.
Yes, sir.
Okay. But in achalasia, generally it's not a feature, but of course you're ruling out
Yes, sir. Malignant
malignant.
causes.
Okay.
Dr. Siddhant,
Yes, sir.
what is globus? What is globus sensation?
Sir, it is, sir, the when the food gets stuck in the lower esophagus.
Right.
Present.
Okay. You have a feeling of something being stuck in the
Yes, yes,
throat.
sir. Yes, sir.
So is that important? How have you, by your history, distinguished whether it is an oral or oropharyngeal or a esophageal or a mixed type of dysphagia? You'll have to distinguish between the three types. How will you do that? Why have you just said that you've come to the conclusion just esophageal? It could be oropharyngeal. By your history, you've not differentiated between the three.
Sir,
Hello.
patient, sir, there was, sir, no history of pain, sir, during swallowing,
That
sir.
is fine. That is fine. Look, if it is oropharyngeal,
Yes, sir.
how will you differentiate between oropharyngeal and esophageal? It is where the food is getting stuck. Where
Yes,
does he
sir.
have? Does he have a sensation?
Sir, the patient will not even able. It is oropharyngeal. He will not even able be to swallow, sir. The initiation of swallowing would be very difficult, sir.
Yes. You should say that after a few minutes of swallowing, there are problems. So when does he have this problem? After how many seconds of swallowing? Is it in the
Sir,
initial phase? It is in the later phase. Do you get me?
yes, sir.
Hello?
Yes, sir. Yes, sir.
Yes.
Yes, sir.
It is important. We
Yes,
have
sir.
to find the location of the problem,
Yes, sir.
right? Yeah. Sir, please, anyone.
Siddhant, why you elicited the history of international travel? History of international travel.
Sir, one of the causes of secondary achalasia is, sir, Chagas disease, which is, sir, Chagas disease more common in South America and Central America.
Why you elicited history of radiation? In what way it is related to the
Sir,
dysphagia?
Sir, causes, sir, stricture formation.
Okay, we'll move on.
Yes, next
Yeah,
slide.
go to your next slide.
Based only on the history, can you grade your patient? Only on the history.
Sir, patient is having, sir, a long for a long time, sir. So grade of dysphagia, sir, is grade 3, sir.
I think Dr. Anian asked about that. Is any grading system available for that? And what are the components of that grade? Okay, there are four points which are there, which are all on the history. One is the dysphagia.
Yes, sir.
Second is the regurgitation.
Yes.
Third is the chest pain. And fourth is the weight loss.
Yes, sir.
So only on history you can grade your patient that what is the severity of that.
Yes, sir. Yes.
So each of these has got 3 points. So you got a total of 12 points. And based on how severe it is, a patient may have a score of 12, or a patient can have a grade of 3 or 5. So it gives you an objective measurement of the severity of the disease. So it is very important to grade the disease, and it will also help with deciding on the treatment. Okay, Siddharth.
Dr. Siddhant,
Yes, sir.
talked to us about Chagas disease,
Yes, sir.
right? Can you mention which are the viruses which are important in contrary associated with Acahalasia?
Sir, human papilloma virus, sir. Human papilloma virus, sir. Herpes
Yes,
virus.
and and measles,
Yes.
right? Good, good. So you should talk about them. Good.
Elicited the history of no history of any previous surgeries.
Yes, sir.
What type of previous surgery is very important in this
Sir,
phase?
any history involving the sir, sir, esophagus, sir, and the thorax, sir.
Okay. Yes, go ahead.
Yeah.
Next slide.
So there is nothing significant in the personal history. He's a non-smoker. I think it's also important to mention that whether he has a history of reflux disease. He said, you mentioned in your history that there is some regurgitation, but
Sir, there is history of dyspepsia, sir.
okay. So history of GERD is important.
Yes, sir. History of dyspepsia.
Siddhant, I think you're logged in 2 devices. Could you just log out from one device? It's echoing
Yes,
a
sir.
lot.
का देख क्यों इको हो रही है, इसने 2 डिवाइस तो नहीं कर रखे हैं, कोई और तो नहीं बैठा हुआ वहाँ डिवाइस के साथ?
Yeah, okay.
हटवा दे उसको, जाके हटा दे, इको कर रही है इसकी आवाज.
Okay,
So
Siddharth. Yeah.
Yeah, Siddhant, examination, please.
Yes.
Why the content is non-bilious?
Yes, sir.
Regurgitation of the food.
Sorry, sir, I cannot hear you.
The regurgitation of the food doesn't contain any bile or it contains bile.
Please go ahead, sir.
Yeah.
Yes. Yes,
General.
summarize.
Yes, sir. Summarize, a 24-year-old male presented with complaints of progressive dysphagia for the past 12 years, initially for liquids, later progressed to solids, associated with regurgitation of food and dyspepsia, not relieved on taking PPIs, with history of on and off weight loss and repeated upper respiratory tract infections. Provisional diagnosis, esophageal motility disorders, likely Acahalasia cardia.
What are the points in favor of your diagnosis of Acahalasia cardia? you want to offer the first diagnosis is Acahalasia cardia. What are points in favor?
Sir, points in favor, sir. The history of, sir, initial history of dysphagia for liquids, then progressing to solids, sir. Then the history of regurgitation of food, on and off weight loss, and, sir, repeated upper respiratory tract infections.
The regurgitated food contains bile or not?
Sir, it was non-bilious, sir.
Why it is non-bilious?
Yes, sir. Sir, due to, sir, sir, no stomach contents, sir, no bile could not come to the up till the lower esophageal,
Acahalasia
gastroesophageal junction.
cardia, Acahalasia cardia is very common in young age or middle age or old age.
Sir, it is common in the age group of 30 to 50 years.
Your other differentials are?
Yes, sir.
What are the other differential diagnoses?
Sir, sir, the other differentials are hypercontractile esophagus, esophagogastric junction outflow obstruction, and diffuse esophageal spasm, sir.
What do you mean by hypercontractile?
Sir, in this, sir, hypercontractile esophagus, the lower esophageal sphincter is in complete contraction, sir, but there is presence of peristalsis, sir, but which differs from Acahalasia cardia, as Acahalasia cardia doesn't have any peristalsis, sir, due to loss of myenteric plexus.
Why can't it be esophagogastric junction outflow obstruction?
Sir,
What is
esophago,
that outflow obstruction?
sir, it can be due to, sir, it can be due to, sir, it is a mechanical obstruction, can be, sir, due to any tumor growth. It can be due to a foreign body, sir.
What is the commonest growth at the outflow? Esophagogastric junction outflow region.
Sir, commonest growth, sir, it can be, sir, esophageal, sir, carcinoma of esophagus.
The other differential diagnosis you are giving is a diffuse esophageal spasm. What is that?
Sir, in this, the entire esophagus goes into goes into spasm, sir. Uh, Due to which, there is no, again, the lower esophageal sphincter is completely contracted, but the entire esophagus is having a p contraction, sir.
Uh, I think, Siddhant, basically what you're trying to say is it is a benign problem
Yes, sir.
rather than a malignant problem. I think
Yes,
it's very difficult to diagnose. You can probably say it is a motility disorder, but
yes,
to
sir.
go on to the extent of saying what type of motility disorder, I mean, achalasia is the commonest. So you can say that that is why I'm saying that as a commonest.
Yes,
But
sir.
you've listed so many other things, which is very difficult from the history. In fact,
Yes, sir.
diffuse
We need
esophageal spasm,
investigation.
there is no
Yes,
chest pain. So it cannot be diffuse esophageal spasm. So
yes,
I
sir.
think it is better not to go into the so much of details of the differentials. I think more like what you're saying is right. It is likely to be a motility disorder. And the commonest
Yes,
motility disorder that you encounter is achalasia. So therefore, you think it is achalasia cardia. But
yes, sir.
it could perhaps even be a benign stricture of the esophagus due to reflux. Okay, you can
Yes,
have
sir.
benign webs in the esophagus.
Yes, sir.
So
Patrocirculi,
all
yes.
those are still possible. So I think in your differentials, you should probably mention those benign things rather than going into the subtypes and the subtypes of the uh, motility disorders, which is very difficult to say from the history.
Yes, sir.
Okay,
Yes.
you really need a manometry to diagnose any of these.
Yes,
So
sir. Yes.
without those, I think it is safer to say benign, other benign causes of dysphagia, such as uh, you know benign strictures, reflux strictures, and perhaps even esophageal webs can cause this kind of problems. So I think that is a better way of saying.
Yes.
Okay, you can move on to the, for want of time, we'll move on to the your findings.
Yes, sir. Sir, general physical examination. The patient was conscious, oriented to time, place, and person, comfortable, thin built, malnourished, dehydrated, with good oral hygiene, with a BMI of 18.66 kilogram per meter square. Uh, vitals vitals were hard, sir, were stable, with a respiratory rate of 18 per minute, which was slightly higher. Uh, on general physical examination, sir, pallor was absent, icterus was absent, clubbing was absent, cyanosis was absent, no lymphadenopathy or no pedal edema was present. On systemic examination of the abdomen was scaphoid, umbilicus, central, and inverted. No visible scar marks, no visible lump or peristalsis, no distension, no obvious swelling at hernial sites, and external genitalia were normal. On palpation of the abdomen was soft, no tenderness, no palpable lump, no hepatomegaly, no free fluid, no cuff impulse over hernial sites. Uh, on percussion, the liver span was 10 centimeter and there was no free fluid. On auscultation, bowel sounds are present and propulsive. Uh, there was no significant findings on the digital anorectal examination and on the neck examination. There was no palpable or obvious swelling in the neck. On respiratory examination, however, there was a coarse crackles heard in the bilateral lungs at the base. Other system examinations were also unremarkable.
What could be the reason for the coarse crackles in the bilateral lungs at the base?
Sir, they signify, sir, long term, sir, consolidation in lungs, sir, due to the multiple attacks of respiratory tract infections.
Okay, in the abdomen, no findings, obvious findings, no mass,
Ye-
nothing.
Yes, sir. Yes, sir.
Okay,
Siddhant,
Dr.
one,
Sir,
sorry, sir.
please.
Yeah, you go
No, no,
ahead.
it's all yours.
So Siddhant, basically, I think in this particular patient, uh, just go to the general examination, please.
Yes, sir. The only finding was that the patient was, sir, malnourished, sir.
Okay.
And
So what did you look for? Why are you saying this patient is malnourished, or what are the things that you can in your examination tell you that a patient is malnourished?
sir, reduced skin turgor, sir, and the hair dry, coarse hair, sir, brittle hairs, brittle nails, sir.
Mhm. Any other?
Sir, loss of, sir, the bulk, sir, the muscle bulk is reduced, sir. The patient doesn't have any bulk of the muscle.
Siddhant, there are
Yes, sir.
there are anthropological factors and there are biochemical. You get me?
Yes, sir.
These
Yes,
are
sir.
the two ways we decide whether the patient is malnourished.
Yes,
So
sir.
anthropologically, you can see his BMI is low,
Yes,
but
sir.
not that much. Does he have any external signs of malnourishment, anemia, fissures at the angles of the mouth, and
No,
his tongue smooth?
sir, no, sir. There were no signs of
Right.
this,
So
sir.
why are you calling him? He's got anemia. He's not got pedal edema. He's not got any ascites. No swelling anywhere. Why are you calling him that? Saying that he's malnourished? There are no skin
Sir,
signs. His oral hygiene is good. Why do you say he's dehydrated?
sir, for a 24-year-old male, sir, the patient is only, sir, his growth is quite stunted, sir. He was just 150 150 centimeters, sir, and
Yes. Look, Dr.
his
Siddhant,
weight was
Dr.
also
Siddhant,
very low,
Dr.
40.
Siddhant,
Yes, sir.
height. If his parents are short, you don't expect him to be 6 feet tall,
Yes, sir.
right? So that is not the reason.
Yes,
His
sir,
BMI is
and
low, but he
yes,
doesn't
sir.
have any other features of malnourishment. Except for low BMI, how have you labeled him as malnourished?
Sir,
Generally, malnourishment goes with malignancy. So I think you need to be very careful when you said everything is benign and then you're saying patient is malnourished.
And 15 years of achalasia can lead to malignancy,
yes, sir, yes, sir.
right? What is pseudoachalasia?
Sir, pseudoachalasia, sir, is a secondary achalasia mainly caused due to, sir, involvement of the lower esophageal sphincter due to a malignancy of the esophagus or
Exactly,
the surrounding structures like bronchogenic
exactly,
carcinoma.
exactly, exactly.
Yes, sir.
Sir, Professor Sir,
What is sigmoid esophagus?
Sir, it is, sir, mega esophagus found in type 1 achalasia, sir, due to, sir, long-term stasis of the,
Sorry, it was a mistake.
what is the normal diameter of esophagus?
sir, normal diameter, sir.
If you say achalasia is dilated, then what's the normal diameter of esophagus?
Normal diameter is 5. Sir, 2 centimeter, sir.
2 to 3 centimeters, less than
Yes,
4
sir.
centimeters is normal.
Yes.
What is the total length of the esophagus?
Sir, it start from we sir it 50 for total, sir, 30 25 to 25 centimeters, sir. If we measure from the incisors, incisors to, sir, oropharynx, it is 15 centimeter. Then oropharynx to, sir, lower esophagus, it is 25, sir.
So Siddhant, basically on examination, you found that it was pretty unremarkable, right? Your
Yes.
abdominal examination was. Just go
Yes.
on to your next slide. Just let's just see that. Yeah. So he has not had any. I mean, everything else seems to be normal. Obviously, he's got a scaphoid abdomen,
Yes, sir.
right? And otherwise, things are okay, right? So now, with your history and your examination, just the next slide, you have mentioned about yeah. So all this is normal,
Yes.
and you also just go on to your next slide, please. Okay. So the next one. Okay. So the neck examination, you said no significant findings.
Yes, sir.
Yeah. What significant findings?
Sir,
Are you?
we look for, sir, any, sir, an enlargement of the thyroid, sir, and any lymph node enlargement, sir, in which may cause the mass effect that cause the dysphagia, sir.
Hmm, okay. So you're looking for any other obvious swellings
Yes,
in the
sir.
neck which can account for
The
uh,
dysphagia, sir.
dysphagia. Okay. So with all this findings, what is going to be your diagnosis?
Sir, based on my history and examination, the diagnosis is still, I will like to keep it as an esophageal motility disorder, sir, only.
Okay. So you don't want to change your diagnosis. You have written the same thing again here.
Yes. Yes, sir.
Okay. So if this is going to be your provisional diagnosis and differential diagnosis, how would you like to proceed? So we'll go on to the investigations now.
Sir, firstly, sir, the first investigation, sir, I will like to do an upper GI endoscopy, sir.
You want to do an upper GI endoscopy.
Yes, sir. Upper
Why
GI
not?
and
Why
but
not a barium study?
sir, we can sir upper GI. Sir, we can do a barium study where it will, but sir,
What a, Dr. Siddhant, what about a plain X-ray chest?
sir, a plain X-ray chest will show us, sir, air fluid levels in the mediastinum.
Exactly, that's the first thing you'll do.
Yes, sir.
Yeah.
What are the other findings in the X-ray chest of Acahalasia cardia? One is air
Sir,
fluid level.
air fluid levels are loss of fundal gas shadow. Yes, sir.
Then what is sigmoid esophagus?
Sir, dilated esophagus, sir, dilated esophagus found in type 1 Acahalasia cardia, mega esophagus, sir.
Can you see on the plain X-ray chest?
Sir, it will show, sir, a widened mediastinum, sir.
What type of the barium study you will do in this patient?
Sir, barium swallow, sir.
What is time barium esophagogram?
Sir, sorry, I didn't.
What is time barium esophagogram?
Sir, we take for, sir, one controls, sir, we give, sir, barium meal of around 250 ml, sir. We first we take a control X-ray, then we after the intake of the barium, we take the first film at 60 seconds, then the next at the second minute, and then after 5 minutes, sir.
So that is what is called the time, no?
Yes,
That
sir.
you have to take it the multiple times. Yeah.
Yes, sir. 1, 2, and 5 minutes with a control.
Why it's being taken in 3 times? 1 minute, 2 minutes, and 5 minutes.
Uh, sir, in the first minute, it reaches the lower esophageal sphincter, sir, and then there we see a, sir, bird beak, or, sir, no, we can see a dilated esophagus, and then the contrast will leak into the at the second and fifth minute. The contrast will start to leak into the stomach, sir.
How it is being done? Barium swallow. How much amount of barium?
Sir,
Any
around, sir,
idea?
200 to 250 ml, sir.
What is dysphagia lusoria?
The dysphagia lysoria, sir, is due to, sir, uh, seen in condition.
Anything related to the blood vessel?
Yes, sir, sir. It is due to, sir, subclavian artery, sir. Dysphagia lusoria, sir. It is the, sir, when it is the origin of the subclavian artery which differs, sir. Sir, in some cases it is in between the esophagus and the trachea. In some cases it is behind, just behind the esophagus, and in some cases it is just out, in front of the trachea, sir. The subclavian artery, sir, compresses the esophagus, which causes the dysphagia.
So at the time barium when you're doing, at the time interval 1 minute, if you find that there is some obstruction is there, that will be suggestive probably because of the dysphagia lusoria there.
Yes, sir.
Okay, so you start with the least invasive, like, obviously you'll do a chest X-ray, you even consider a barium. But what next?
Sir, the gold standard to diagnosis Acahalasia cardia is, sir, the high resolution manometry, sir.
No. Well, you said an upper GI endoscopy, correct?
Yes.
Okay. So why do you want to do an upper GI endoscopy in uh, in this
Sir,
particular patient?
we can rule out sir pseudoachalasia, sir. The growth of the esophagus can be seen, sir.
So, assuming that you're doing the endoscopy, uh, what will you find when you do an endoscopy for this patient?
Sir, in achalasia, we will find sir, remnant food in the esophagus, sir. There will be sir, there may be mucosal changes, sir, which such esophagitis, sir, mainly. And there can be sir, if long standing, there can be candida infection as well, sir.
Sorry.
Okay, Dr. Siddhant. So
Yes, sir.
you've made the diagnosis of Acahalasia cardia.
Yes, sir.
You've done a high resolution multi HMR endoscopy and come to that. Now, how do you treat this patient? This patient, you said, has undergone multiple surgeries.
Sir,
Hello.
sir, there is no issue of any sir previous surgery. This patient has undergone only this once, sir. We have operated
What?
on.
Yes, so you've not given us this in your history.
Sir, I've
There is no history of any previous surgeries. You're saying there is a surgery. Hello.
sir, this time only when we operated, sir. This is a post-op case, sir.
So when did you operate? You just in your history that you give us. Give us the history that you operated. Okay, let's see your investigations first. Let's see
So
your investigation.
shows the barium study. Yeah. Okay.
I say that this is a malignancy of the lower end of esophagus. Prove me wrong.
Sir,
So why are you saying that this is achalasia?
sir, presence of sir bird beak at the end, sir.
Okay.
Anything else? Anything else which is important?
Sir, the dilated esophagus, sir.
No.
In a
For
carcinoma
malignant.
esophagus, the history is short, sir, which will not cause such dilatation, sir.
We're not talking about history. By your barium, can you make out whether it's malignancy or it is achalasia?
Sir, in malignancy, sir, there is apple, sir. Oh,
Right. Okay.
yes.
There'll be apple core or there'll be some
It's
growth.
classically the rat tail appearance, no?
Yes, sir, right tail appearance.
Yeah, rat tail appearance. Yeah.
Yes.
Right. Okay. What else? You've done this. Now what?
Yes,
Why
sir.
did you go in for surgery? Why did you go in for surgery for this patient? Why? What are indications for medical management?
Sir, sir, if the symptoms, sir, the grade according to the grading of sir achalasia, as sir, if the symptoms are not, say, if the patient is just having sir reflux, and then we can go for medical management by sir nifedipine and verapamil, sir.
So why did you give it a trial, a medical trial?
Sir, he was being treated elsewhere. He has already undergone sir medical management, which sir did not give him
Okay.
any relief.
So what is the basic cause of achalasia? What
Sir,
is the
the
basic cause of
pathophysio yes, sir, the pathophysiology is sir the loss of myenteric plexus, sir. The destruction
why?
of the myenteric plexus,
Why?
which
Why?
Uh,
Why? Why? How does it get destroyed?
Sir, the exact sir etiology sir is unknown of the destruction, sir.
It is autoimmune.
Sir, sir it can sir but it will be sir secondary achalasia.
What's secondary?
If it will become a secondary achalasia, sir, if it is autoimmune, sir.
Okay. So what
The
is the primary
primary
one?
achalasia, sir, the mechanism of sir the destruction is unknown, sir.
So it is usually assumed that there is some sort of inflammation and destruction. Can be
Yes, sir.
autoimmune, can be because of any secondary thing. Okay. And so what does it result in?
Sir,
What happens?
the inhibitory neurons that cause the relaxation of the lower esophageal sphincters are lost. Mainly the nitric oxide and the vasointestinal peptide,
So
and
what's
the
the normal pressure?
acetylcholine.
So what do you call normal pressure? What's the normal pressure of lower esophageal sphincter?
The lower
What is
esophageal
it high pressure?
sir, it is
Okay.
less than 15 of mercury, sir.
So more than 45 millimeter of mercury is defined as high pressure. Okay.
Yes, sir.
So you've done this. Any other investigation?
Sir, we go for the for gold standard is the high resolution, sir, manometry, sir.
You've done that?
Yes, sir.
Yeah. So what did you find? It's too small. I can't see it. What did you find?
The high resolution manometry showed no wave patterns, only a single color, which is suggestive of sir type one achalasia, sir.
So that shows that there's constant increase in pressure,
Uh, yes, sir.
right?
There is no relaxation of the LES and no peristalsis and no.
Yeah. So
Yes,
if
sir.
it was malignancy, there would be at least waves of peristalsis.
Yes, sir. Yes, sir.
Okay. Now next slide, please. You've done an upper GI endoscopy also?
Yes, sir. The second photo, sir.
Yeah. So what does that show?
So the second photo shows the esophagus was distended and filled with residual food. Mild resistance was noted at the G junction, but no growth or ulcer. It was
Now what? Now what? Next step.
sir. We have diagnosed on the esophageal manometry as type one achalasia. We go for a
So
sir.
what's the ideal treatment for type 1?
Sir, type 1 ideal treatment is laparoscopic fundoplication with Heller's myotomy. Laparoscopic Heller's myotomy with partial fundoplication.
No, what about dilatation? Can you do a dilatation?
Sir, we can go for pneumatic dilatation, but the best treatment is uh, the
No, you have to
surgery.
give it a try. You have to give it a try. You get me?
Sir, but if we give a pneumatic dilatation trial and it fails, sir, then the surgery would become difficult, sir.
Why? Why? Why would
Sir,
it become difficult?
due to the mucosa injury, there would be chance when during the surgery there will be chances of sir, perforation of the mucosa, sir.
No, that if you dilate it too much. Well, you can always going for dilatation and see. He's a young fellow. How old is he?
Sir, 24-year-old.
24. Okay. So you've done what? You've done Heller's myotomy?
Laparoscopic Heller's myotomy with partial two-pay fundoplication.
Okay. So how does this differ from poem?
Sir, poem is sir. Do we go through the oral cavity and endoscopically, and there no fundoplication is can be done, sir. There is only myotomy is done, sir.
Okay, suppose this patient had Barrett's,
Yes, sir.
then what would be your treatment?
Sir, in sir Barrett's we Sir, for Barrett's, we'll go for a nascent fundoplication.
Let's go for nascence. What is Barrett's?
Sir, Barrett's is the malignant lesion of sir.
He's 24. He's gonna develop malignancy sooner or later.
Yes, sir.
What would your treatment be now? Going for esophagectomy, no?
Sir,
Barrett's, Barrett's is a indication for esophagectomy. Both are can predispose to malignancy. You
yes,
get
sir.
me? Okay. So anyone, sir?
So, just as this manometry that you have shown here, I think,
Yes.
as sir was saying, I think at your level, basically, you should probably know how to sort of interpret the thing without going
Yes.
into too much of details.
Yes,
So,
sir.
in Acahalasia, there are three components. Okay, so
Three types,
basically,
sir. Yes, sir.
three components of it. Basically, there will be increase in the lower esophageal sphincter pressure.
Yes, sir.
So you can see the line there, which is in red and yellow. So that's the
Yes,
lower
sir.
esophageal sphincter,
Yes,
and
sir.
there is an increase in the pressure. The
Yes, sir.
second component is loss of relaxation. So
Yes, sir.
normally when you take food, the lower esophageal sphincter relaxes.
Relaxes.
So the basal pressure is high. The second
Yes.
component is there is no relaxation because of the food coming down.
Yes, sir.
And the third component is hypocontractility. So
Yes, sir.
the body of the esophagus, there is no contraction. So that's why
Yes.
it is totally green. So there is no
Yes, sir.
contraction. So this is, the
Type.
classical of type 1 achalasia.
Yes.
So the three components you should be able to tell. They may ask you in your exams. So
This was asked
increase.
last year in their OSCE.
Yes, sir. So I think at your level, you should know what are the three components that you're looking at when you look
Yes.
at the manometric thing and how it helps. And of course, there is, as sir was saying, there are different, uh, methods of treatment, endoscopic
Yes.
methods, and of
Yes, sir.
course, the surgical methods. What you did not mention is botulinum is also used, but that
Yes,
is
sir. Yes, sir.
basically in patients who cannot
Who cannot go
withstand
for
surgery
surgeries?
or
Yes, sir.
endoscopy.
Yes, sir. Yes.
Usually elderly people,
Yes, sir.
that may be tried. But if it is, a young patient, then perhaps either a POEM or a laparoscopic Heller's myotomy is the
Yes, sir.
treatment of choice. And you should know a little bit about each one to uh, explain when you're asked in the exam.
Yes, sir.
Okay.
What is the expansion of poem?
Sir, sorry.
What is the expansion of poem? POEM.
Sir, peroral endoscopic myotomy.
What are the complications of poem?
Sir, complication, sir, it can cause, sir, GERD, sir.
Then what is third space endoscopy? What is third space endoscopy?
Sir,
Dr. Akhilesh, can you please mute yourself? Dr. Akhilesh, please mute. Yes, then what is third space endoscopy?
sir, third space, sir, sir, it is done submucosal in the submucosal plane, sir. Submucosal layer, the third space endoscopy.
Is the poem a third space endoscopy or not?
Yes, sir. We go. Yes, sir. Yes, sir.
Yes, it is, no?
Yes,
What
sir.
are the other indications of doing the third space endoscopy?
Sir, sir, third space endoscopy, we can, if there is a, sir, submucosal, sir, tumor, sir, like.
Okay, submucosal tumor is there, like the gist is
Yes,
there. You can do
yes, sir.
that.
Yes, sir.
Okay. Anything in the neck?
Sir, next, sir, Zenka's diverticulum, sir.
Janker's diverticulum. Anything in the colon, you can do that?
Sir, colon, sir.
Can
Sir,
you
I
get a
don't,
motility disorder in the colon?
sir, colon, motility disorder, sir, Hirschsprung's disease, sir.
In the Hirschsprung's, yes.
Yes, sir.
Hmm. Now, when you are doing the laparoscopic Heller's myectomy,
Yes, sir.
what is the length of the myectomy you are doing?
Sir, the proximal portion is around 5 centimeter towards the esophagus, I mean, and the towards the stomach it is at 2.5 to 2.5, sir.
And what precaution you
Sir,
take at that time when you're doing this Heller myectomy?
sir, sir, we have to avoid, sir, injuring the mucosa, sir,
Okay.
not to perforate the mucosa, sir.
Right. If by the way you have injured the mucosa, then what you will do?
Sir, we will do a, sir, 270-degree wrap, sir. Sir, door fundoplication.
The door one. No? What is
Door
door?
fund.
What is tupe and what is nishan?
Sir, door is anterior fundoplication, tupe is posterior fundoplication, and Nissan's is a 360-degree wrap, sir.
So if you have injured the mucosa, you will do the door type and the
Door, yes, sir,
anterior
yes.
one. No?
Yes, sir.
Yes. You know any special instrument which is used for doing the Hellers?
Sir, Nathanson's retractor, sir.
No. How do you cut it? It is by some Indian surgeon who has made that. Who is the most popular endoscopic surgeon in India? He's from South.
Sir, anyway,
Dr. Pelnivelu, है ना? He has a special instrument for that, for doing this Heller's myectomy, so that there is minimal injury to the
Liver.
mucosa, है ना?
Yes.
Okay.
Can we finish this question?
Yeah, I think we can. Yeah, we can go for the second one.
Sir,
Yeah.
Sir, I have video if there is time, sir, of the
Yeah.
surgery.
Show. Yeah. Show the
Yeah,
video.
sure.
Yes.
Thank you. Good luck. Hemant sir, thank you.
Yeah, thank you, sir. Thank you.
Let's go. Sure.
Siddhant, can you explain the steps?
Yes, sir. Yes, sir. Sir, we are trying to mobilize the fundus, sir, here in this. Sir, here we are trying to, sir, separate.
What you are separating there?
Sir,
mobilizing the esophagus.
What is
sir,
that in?
sir, we are trying to pull down the esophagus from the. Then this we are doing the.
Fund application.
Sir, this is a shoe shine maneuver. This was done.
But
Yes,
have you
this
done
one.
have,
This one, sir.
before the shoe sign, have you done the myotomy in this patient?
Uh,
Where is the myotomy?
This looks like a fundoma, Mason fundo. Are you showing the right video?
yes, sir. This was a two-pay, sir.
So he will show it, I think, after that. Forward the video little bit.
Yes, sir. Sir,
This
this
is
part,
the
sir. This is the myotomy.
Yeah, this you are doing. Yeah.
Yes, sir.
Mhm.
Yeah, right.
Yes.
Mhm.
So where do you start the myotomy first?
Sorry, sir.
Which part of the G junction you start the myotomy first?
Uh, sir, sir, proximal in the proximal part, sir. First.
Just above the G junction. That's the
Yes,
right
sir.
place to start. Half a centimeter,
Yes, sir.
1 centimeter above the true G junction.
Yes, sir.
How do you handle the telemucosal bleedings? Because as you split the muscle, you do expect little amount of bleeding from there. What did you do for control of bleeding?
Sir,
About it. How do you know that you have done complete complete division of external fibers?
sir, sir, the voice is distorted, sir. I didn't get you, sir.
Where anatomy? How do you listen to anatomy?
Sir,
By looking
the
at the
internet connection
dissection.
is, sir. Sir, internet connection is a bit.
There is no circular muscle fiber, only bare mucosa is seen. Usually mucosa bulges out. All right.
Yes. Yes, sir.
So what is the recommended fundal strengthening augmentation procedure after a standard Acahalasia myotomy? What are the
Sir,
types of fundal application you know?
sir, the door fundoplication, that is the anterior, the toupee, that is the posterior, and the knee sense, that is the 360-degree wrap, sir.
What is the ideal myotomy for these patients? You do, like after myotomy, you do fundal procedure following myotomy.
Sir, sir, I'm unable to hear you, sir.
No, when you do a myotomy, what is the
Yes.
requirement for doing a fundal augmentation?
Sir, if we just do a myotomy, it will cause, sir, reflux disease, sir. If we don't do a fundoplication,
Alright, so they will become a volume reflexer. The people will become volume reflexer.
yes.
Do you have any clue after this fundal strengthening procedure? How many percent of the patient requires a proton inhibitor
Sir,
after a myotomy, after a proper fund application?
sir,
Sorry?
recurrence.
No. See, generally these patients, how much ever you do good fundal augmentation procedures, like
Yes, sir.
G-junction augmentation procedures,
Yes, sir.
they still continue to have reflux. We cannot give a near normal anti-reflux procedure,
Yes, sir.
natural way.
Yes, sir.
So these patients do require post-operative follow-up and then post-operative medication for controlling the heartburn symptoms.
Yes, sir.
So my question is, what is the percentage of the patients who undergo myotomy require a PPA usage?
Sir, I
All
don't
right,
know.
please go read about it.
Yes, sir. Yes.
Studies differ, the extent of gastric site myotomy, if it is more than 1 to 2 centimeter, the
Yes.
requirement is very up till almost 7 to 8%. If
Yes,
you
sir.
want to do less than 2 centimeter from the 5 centimeter of cerebral myotomy, generally the requirement is up to 30%. All right. Below
Yes,
it,
sir.
if you do myotomy, the risk of
Sir, there is no audio. Sir, I'm unable to hear.
I think
Sir, the connection was
I
lost,
don't know
sir.
when I got last.
Yes.
No problem. Are you able to hear me now?
Yes, sir. Yes, sir.
Right. See, normally when you do a myotomy, the success of myotomy and success of fundal augmentation procedure should be patient has no reflex and no dysphagia. This is a
Yes.
typical outcome what you expect.
Yes, sir.
Fundamentally, the Acahalasia cardia esophagus is never a healthy cardia. There is no residual peristalsis. Innately, there
Yes,
is
sir.
a neuromuscular decompensation of the entire
Decompensation.
swallowing mechanism. So these
Yes, sir.
people will have sort of dysphagia. The concern
Yes,
will
sir.
be dysphagia. Concern will be gas bloat. Gas bloat, when you do the fundoplication, the swallowed air cannot come out of the fundoplication. These are the two important things. Difficulty to burp. That's a very typical word the patients tell. So these are
Yes.
the two concerns you see the post-operative period. What are the
Yes.
typical immediate perioperative complications of fundoplication?
Sir, sir, mucosal perforation, sir. It can cause, sir, during
Technically,
surgery.
it's not a good one.
Yes, sir.
I'm telling second day, patient is telling abdominal distension, pain along the left shoulder.
Sir, there can due to sir, there can be sir pneumoperitoneum, sir.
Because of
Sir, because of sir, not
why pneumoperitoneum comes. Of course, pneumoperitoneum. I agree with you. Why pneumoperitoneum comes?
sir, the improper fixation of sir at the cruroplasty. If sir, it is improper, it can
It's
cause.
RAP migration.
Yeah.
When is
Yes,
the technical problem can manifest at the
sir. The connection is getting
this
in between.
pneumoperitoneum. Right, I'm with you.
Sir, the connection is getting lost. I'm
Which is
unable
the
to hear.
thinnest part of the stomach? Which is the thinnest part of this?
Sir, I cannot hear the voice is distorted.
Sir, please go, sir. I think my network is. Please.
Thank you. Yeah, Dr. Siddhant.
Yes, sir.
Yeah, I think we'll finish this off here. Thank you so
Yes,
much.
sir.
You've done very well.
Thank you, sir.
So, any assessment of for Siddhant? Or you hang on, Siddhant. We'll talk about your performance after the second presentation.
Yeah. Okay, sir.
Yeah, who's the second candidate? Who's the second candidate?
Thank you, Hemant sir, and thank you, Siddhant. You can stay
Thank
back
you,
for
sir.
the next case discussion.
Yes, sir. Yes, sir. Thank you, sir.
Thank you.
Dr. Surya,
Sir, yes, sir. Can I
please
share the
share
slide?
your PowerPoint and start your presentation. Sir, kindly take over. Hemant sir, if you have time, I will be happy if you can stay with us for this discussion. Sir,
Yeah,
can I
yeah.
request you?
Yes,
Sir,
yes.
can you able to hear me, sir?
Yes, yes, yes.
Sir, my name is Dr. Surya from Madurai Medical College. I am thank my HOD and for providing this opportunity. Today, I am going to present a case of varicose vein. This is a clinical picture so demonstrating varices over the lower limbs. A 49 years old male, Kamaraj, coming from Podumbu, who works as a daily wager, came, uh, came with the complaints of dilated and tortuous veins over the left lower limb for the past 3 years. History of presenting illness. Patient was apparently normal before 3 years. Then he noticed the dilated veins over the inner aspect of the left lower leg, which was progressed to gradually involve the entire lower leg, which becomes prominent with standing and walking and decreased on lying down. History of pain over the left lower leg for about 3 months, insidious in onset, dragging type in nature. It aggravates while walking during the end and reduced by elevating the limb and doing massage. History of itching present for about for 1 month. No history of pigmentation or bleeding. No history of trauma, no history of ulcer, no history of any night cramps, no history of paresthesia or numbness in the lower limbs, no history of intermittent claudication, no history of fever, no history of prolonged immobilization, no history of joint deformity, no history of abdominal pain, distension, no history of chronic constipation. The past history, no history of similar illness in the past, no other known comorbidities, no previous history of surgery, no previous history of any DVT, family history, no significant family history in personal history. He consumes a non-vegetarian diet. It's a normal bowel and bladder habits. Sleep and appetite is normal. Not a smoker and not an alcoholic. Summary: a 49 years male, Kamraj, working as a daily wager worker, presented with the complaints of dilated tortuous veins over the left lower limb for the past 3 years, associated with pain for the past 3 months, with itching for the past 1 month.
Yeah, Dr. Surya. What do you think? He's got dilated tortuous veins in the left lower limb, 3 years with pain. Pain where?
Sir, over the calf muscles and legs, lower
In
legs.
the leg. Okay, in the leg since 3 months. And itching where? All of the body.
No, sir, over the lower one of the legs.
Okay. Let's go to your first slide. Dr. Surya, when
Yes,
you
sir.
have a case of any vascular disease of the lower limb, you, by your history, first have to rule out an arterial disease, right?
Yes.
Then then you have to rule out, or you have to prove that it's a venous disease, right?
Yes.
And then what? And in venous disease, if it's varicosities, you have to rule out whether there's DVT, right?
Yes, sir.
So by your history, you have to rule out all this. So
Yes.
let's go to your next. Let's see whether you've done it. 2 years back, he noticed inner. Okay. And dialect decrease in line. Pain in lower left, constant dragging. When is the pain maximum? Towards the end of the day?
So towards the
Yes.
end of the day, sir. Yeah.
So you're right. Look, it aggravates while walking. Why do you think the pain is aggravating while walking?
Because
This
of
is venous.
the
No,
ambulatory venous hyper.
no. Why? What is the correct? In which arterial or venous disorder you have increased pain on walking?
Sir, arterial
That is
disease.
asking this question.
Arterial disease while walking, we get pain on arterial disease.
In arterial diseases, no? So how you will explain the pain on walking? Usually on walking in venous, chronic venous hypertension, the blood returns normally because there is more pumping of the blood by the soleus muscles. So it is not a characteristic of the venous varicose veins that you have a pain while walking.
Sir, in case of venous disease, where the pain get relieved by limb elevations.
So that is due to drainage of the blood, no? And walking leads to drainage of the blood. There is more pumping of the muscles, soleus muscles, which are the heart of the lower limb. Sir is asking this question. So usually this pain is on prolonged standing. That's why it is on the in the evening. It starts in the evening after prolonged
sir.
standing or pooling of the blood. That leads to the pain.
Yes, sir.
So what is venous claudication then?
Sir,
What is venous claudication?
in case of venous claudication, the patient will have a bursting type of pain, which get relieved by elevating his limbs.
So why
Whereas,
does that happen?
because the venous pooling is getting reduced by elevating the limbs.
Why
So
does in arterial, what is arterial claudication?
in case of arterial claudication, the patient walks for the few distance and the patient develops a pain, and then the patient stops walking and he takes some rest,
And why
and
does
then
that happen? Why does that happen?
because
Why
of
does arterial claudication happen?
an ischemia.
Right. Very good. So now why does venous claudication happen?
Because of the venous congestion, the patient.
Exactly. The blood is unable to, all of the blood is unable to go back.
Sir.
It pools there. Now, how will you distinguish arterial claudication from venous claudication?
Whereas in case of arterial claudication, while elevating the limb, it will cause severe pains.
Okay, that is one. Any other way? First, what is the characteristic of arterial claudication?
Pulses
Which
will not be
distinguishes
there.
it from venous claudication?
The patient stops walking and stops walking. Sir.
So in
In case of
arterial
arterial.
claudication, there's a fixed distance. There's a claudication distance. He knows that if he walks from his house to the well or to
Yes,
his
sir.
farm, he will, at that point he will get pain, and he
Yes,
sits
sir.
down and the pain gets relieved.
Yes, sir.
What about venous claudication? Do you have claudication distance here? No, you don't have.
Yes, sir.
He just walks, and sometimes he gets pain, sometimes they don't.
Yes.
And here the pain is relieved on elevation,
Elevation.
right?
Yes, sir.
So you have, while walking during the end of the day, I can't understand pain, burst dragging type of pain, which it aggravates while walking during the end of the day. So the pain is, look, pain is there to maximum towards the end of the day. This
Yes.
walking stuff is different.
Yes, sir.
Don't club the two.
Yes, sir.
Yeah. Okay, itching is present. Why is there itching? Or where is the itching? Maximum.
In the lower one third of the legs. Sir.
Why? What do you
So
think is happening? Why do
because of
why do they get
the
itching?
venous congestion, there is a stasis eczema. The patient will have itching.
No, no, no. Before stasis also there, eczema before eczema also there will be itching. Why itching is there in a patient of varicose vein?
In case of any, because of the venous congestion, there is a lactic acid accumulation. Metabolites like substance P cause irritation
Cause
in the nerves.
pain. That will cause pain. That is in peripheral arterial disease, not in venous stasis. What happens in venous stasis?
Venous
The
stasis, there is
fluid,
accumulation of metabolites which will cause irritation of the nerves.
no, the proteins and inflammatory chemicals they leak into the skin, causing to stasis dermatitis. है ना?
Okay.
It may be without eczema.
Okay.
Okay, so that is the reason for itching in patients of varicose vein, right?
Okay.
Okay.
No history of pigmentation or bleeding. What do you mean by this? Pigmentation where?
So in the lower limbs, legs, lower one third of the legs.
Why? What are you looking for? What does pigmentation tell you? What is lipodermatosclerosis?
The sclerosis of the skin and subcutaneous tissue in case of chronic venous hypertension happens.
So what happens?
Tissue scarring.
Yeah, there's fibrosis. There's progressive. There's leakage from the venous capillaries and the venules, and
Yes.
that thing accumulates in the subcutaneous tissue. You've got RBCs, you've got WBCs, you've got platelets, everything, and they cause inflammation, and then subsequent fibrosis, and it ends up with lipodermatosclerosis. With what is that leg called?
Inverted champing. Inverted
Right.
champagne.
Sclerose there, and the
Yes.
upper portion is still dilated. Okay, next slide, please.
Yes. So no,
Trauma where? Trauma into in the hand will cause this? No history
no,
of
sir.
trauma where?
Sir, lower limb, sir, left lower limb.
Affected limb.
Yes.
He's got varicose on the right side. If he's got trauma on the left leg, will it cause that? No.
No,
So
sir.
affected limb.
Yes.
Ulcer, night cramps. What do you mean by night cramps? What do you want to say? Why have you taken this history of night cramps?
The patient will develop pain during night, sir, because of the accumulation of because of the venous stasis, where the patient is not walking for a prolonged time.
No,
So
so
the venous congestion is more towards the end of the day. The patient develops night cramps towards
you want to rule out arterial disease. What happens? Is there more pain at night?
Yes, sir. There is more pain at night.
Yes, there is. Why?
Because the patient lies down flat, push.
Yes, so they lose that gravity. That force of gravity is gone.
Gravity. Yes, sir.
So you want to you have taken the history to differentiate it from an arterial disease.
Arterial disease.
Say that.
Yes.
Look, you've got everything mixed up. You tell me history of fever here, then you telling me ulcer there, then telling me trauma. You have to look when you're taking this negative history. It should be in traumatic, inflammatory, all that kind of thing. Then arterial problem, you rule it out first. Then you go to the venous, and then you take the history of what is the extent of the venous disease. You get me? It should be, you can't just shuffle everything up here.
Yes,
joint deformity. Which joint are you looking for?
So knee joint, knee and ankle joint.
Knee joint. Why are we looking for knee joint deformity?
So if in case of any trauma, the patient will have joint deformity. It will cause gait abnormality, and it will lead to
history of no trauma. Then why taking history of knee joint? What joint deformity are you looking for? Without trauma. What is equinus deformity?
Sir, the patient will walk in the tip of his toes, sir.
Why does that happen?
Because of the ulcer which is in the the patient tends to walk in the tip of the toes because of the ulcer being painful.
There's fibrosis at the posterior part of the leg, right?
Yes, sir.
Because of inflammation.
Yes, sir.
Abdominal pain, distension, chronic constipation. Okay, next.
So one question. Why Surya have taken history of no prolonged immobilization present?
Sir, to rule out causes of DVT.
You mean to say for the secondary varicose veins?
Yes, sir.
Right? So
Yes,
in that case, only your history will justify that there is increase in pain on walking. Right? So if there is that is venous claudication, a classical example, when there is obstruction to the backflow of the venous blood, then the patient will have severe pain on walking. Right? Otherwise, if there is pain on walking, it is a classically associated with peripheral arterial disease. Okay, go ahead.
In what way the chronic constipation is related to the varicose veins?
Sir, in case of chronic constipation will lead to an increase in the abdominal pressure, sir, which can lead to secondary cause of varicose veins.
What do you mean by primary? What do you mean by secondary varicose veins?
The primary without any identifiable cause. Secondary is due to any pathology, the patient develops varicose veins.
What is the commonest secondary cause in females?
Physiologically, it is pregnancy. The patient will have varicose veins.
Okay.
Yes, Dr.
Past history.
Sir?
Dr. Surya, can you tell us the difference between secondary varicosity?
So sorry, sir.
What are the differences in primary and secondary varicosities?
What are the causes for secondary varicose veins? Sir is asking.
Sir, it can be due to external venous compression like May-Turner syndrome or pelvic tumors, and in case of venous occlusion like iliac vein occlusion, or else iatrogenic injury or trauma, or in case of any abdominal increase in abdominal pressure like constipation and coughing, and in case
Any other
of
difference? Any other difference
any
between
pregnancy,
primary and secondary?
ovarian tumors, pelvic tumors.
No, all other causes. Tell me four different causes, differences between primary and secondary varicosities.
Sir, in case of
It is seen at a
primary
young age.
varicosities, it will occur in the young age, sir. Whereas
Yeah.
in case of
Then,
secondary varicosities, it will occur in the
okay,
later age.
age. What else?
In case of primary varicosity, the patient will have long-standing saphenous, superficial saphenous system involvement, sir. In case of secondary venous system, where the patient will develop an acute swelling, so followed by the patient will develop some varicose veins, sir, in case of secondary.
Look, in primary, only the saphenous distribution is involved.
Yes, sir.
In secondary, they're both the saphenous, the perforators, and the deep veins. They're all involved,
Yes.
right?
Yes, sir.
There's family history in primary. There's no family history in secondary. Only SFJ, because only saphenous distribution vein is involved, only trendant plus 1 will be positive.
Yes.
There'll be no sequelae to stasis, no dermatitis, no ulceration, no more ankle edema. You get me?
Yes, sir.
The deep veins will always be patent.
Yes, sir.
Look, primary means the deep vein is okay. It is just that the saphenous veins
Yes,
alone are involved
yes.
because
Yes,
of some hereditary problem. Right?
Yes.
You get me?
What is Klippel-Trenaunay syndrome?
Sir, it runs
Klippel-Trenaunay syndrome?
varicose veins where runs in the families because the patient have congenital disorders like Klippel-Trenaunay syndrome, where the patient will have lateral varicose veins, capillary hemangioma, and then deep veins, hypoplastic deep veins.
What happens to the bulk of the limb?
Hypertrophy of the limbs.
Hypertrophy.
Limbs can be seen.
You are
What
told
is the
something
cause?
about a med.
What are the
Med-
pigments which are there in the causing the pigmentation of the limb? Which pigments are involved?
Sir, because of the venous hypertension, where there is RBC will through the capillaries leak, and it will form RBC breakdown, and heme will deposit and form hemosiderin deposition, causes pigmentation, sir.
Yeah, hemosiderin and
Melanin.
melanin. Yeah, yeah. These are both the pigments which are there which cause the pigmentation.
You have mentioned about that May-Turner syndrome. What is that syndrome? Surya.
Sir, in case of it is an external vein compression due to an artery, sir, where left common iliac vein is compressed by an right iliac artery, sir, right common iliac artery, sir, where the patient will have left varicose veins, secondary varicose veins.
Usually in which limb, lower limb, varicose veins are very common. Left lower limb or right lower limb?
In left lower limb, sir.
Varicocele is very common in left side or right side?
Left side, sir.
Why?
Sir,
What is
because
varicocele?
sir, it's a dilated pathniform for fluxes of veins in the testis,
What,
sir.
what are family-form plexus?
The veins that drains the testis.
Testicular veins.
Testicular veins.
Okay, why it's very common on the left side, varicocele?
Sir, it drains right angles to the right drain. Usually in the right side, it directly drains on the aorta. In case of left side, it
Aorta.
drains right side testis.
Aorta.
The vein, it's directly drains into Internal iliac vein, sir. Sorry, sir. Internal
iliac artery, right side.
vein,
Directly
sir.
into
Directly into
which vein?
IVC, sir. IVC, sir. Sorry, sir. IVC. IVC. Directly into IVC, and in case of left side, it will drain into left renal vein, sir.
At an acute angle or
At an acute angle, sir.
Any other reason?
Sorry, where the left arterial veins also parallelly, opposite side parallel drains into the left renal veins.
Okay. What are the other sites in which we can get varicose veins or varices in our body, except the lower limb?
Sir, esophageal varices can be seen, sir. And case of hemorrhoids can be seen.
Yes. Rectal varices.
Rectal varices.
What is caput medicae?
Dilated veins over the abdomen, sir.
Okay. Right, go ahead. Past history. Go ahead. Past history.
So past history, no history of similar illness in the past. No other known comorbidities. No previous history of any surgery. No previous history of DVT. Family history, no significant family history.
What type of surgeries you will ask? Previous surgery.
So any pelvic surgeries should be asked.
Okay. Sleep and appetite normal, not a smoker and an alcoholic. Personal history. Right, okay. So what's
Summary
your
of
diagnosis after summarizing the history?
So where the patient have dilated veins over the lower limbs which get the pain get released when elevation of the limbs. I will think of it is purely an varicose vein swelling, so I am go with the diagnosis of left varicose vein.
What is the definition of varicose vein? What is the definition of thread veins? What is the definition of another vein? What is that called?
Reticular vein.
Reticular.
Reticular vein.
Sir, where there is in case of varicose vein, it is a dilated, tortuous, elongated veins which is more than 3 mm in diameter with a demonstrable reflux. In case of thready veins, which is less than 1 mm in diameters. In case of reticular veins, it is 1 to 2.9 mm in diameter, sir.
In which group of people varicose veins are very common?
Sir, the person who are working in long-standing working profession. Sir, they are
what professor? Working professor.
So who are standing for the long hours, they can develop a varicose vein, sir.
Okay, then traffic police.
Traffic police and the surgeons, we are also prone to develop.
Surgeons. Okay, what is the longest vein in our body?
Sir, the longest vein in our body is a great saphenous vein, sir.
How many valves are there in the great saphenous vein?
Sir, in case of great saphenous veins, there is 12 to 20 valves seen, sir.
20 valves. How it is formed and where it drains?
Sir, it is formed by an medial dorsal venous arch, and it passes above the medial malleolus, and it passes through the medial side of the leg, and it courses behind the femoral condyle, and it passes medially through the thighs, and it will drains into the saphenous opening at the subfemoral junction.
What is cribriform fascia and where it is present?
Sir, the saphenous opening is made through the cribriform fascia, sir.
What is the surface marking of the saphenofemoral junction?
Sir, it is 4 centimeter below and lateral to the pubic tubercles.
What are the 6, 4 or 5 or 6 named tributaries at the saphenofemoral junction?
Sir, there are 6 named tributaries which drains GSV. They are superficial external pudendal vein and superficial deep pudendal, and there is a deep external pudendal, and there is a superficial inferior epigastric, superficial circumflex vein, and medial and lateral accessory veins, posteromedial and anterolateral accessory veins.
Okay. Your case is, so it's the varicose vein on the left lower leg. Okay, how will you proceed?
So
how will you manage
proceed
this
within
case?
Where are the perforators in the GSV? In the leg?
So in the
Is it along the main trunk or it is different?
in case of legs,
Sir is asking what do you mean by direct perforator and what do you mean by indirect perforator? Any idea?
In case of direct perforators, which directly communicates with the superficial to the deep venous system. In case of indirect perforators, it arises from the superficial system, it joins with the muscular vein and then drains into the deep venous system, sir.
I was asking that what are the main perforators
Sir, in
the leg region? Are they along the main saphenous vein or its branch?
Sir, in the legs, it is on the branch, sir.
Yes. Which branch is that?
Sir, in case of below knee perforators, where posterior tibial drains the GSV, sir.
Called a posterior arch vein.
Posterior arch vein.
Yeah. So all those perforators which are the main perforators, they are not along the main tributary. It is along these branches which are there. Posterior arch vein. Okay.
Yes, sir. Yes.
Yeah.
Which cutaneous nerve is going along with the great saphenous vein? Which cutaneous nerve is with the short saphenous vein?
Sir, with great saphenous vein, saphenous nerve is seen, sir.
Yes.
Whereas in case of short saphenous vein, sural nerve goes along with the vein.
Sural nerve. Sural nerve. Very good, super. Yes. Go to the general examination. Fast. Quick.
So general examination, patient was conscious, oriented, afebrile, well built and nourished, no pallor, cyanosis, icterus, lymphadenopathy or clubbing. Vitals were pulse rate was 84 per minute, blood pressure was 130/80 in the right upper arm. Examination of the lower limb. After getting informed consent from the patient, he was examined in a well-lit room. After exposing him from the umbilicus to the toes, inspection, gait was normal, attitude of the both limbs was normal, left lower limb. On standing, dilated elongated tortuous veins were seen along the medial aspect of the lower leg, thighs, and the anterior and medial aspect of the upper leg. On elevation of the limbs, the dilated veins will disappear. No edema or ulceration, no hyperpigmentation with eczema, no loss of hair, brittle nails, dry skin, or loss of subcutaneous fat, no sinus or redness. On palpation, no local rise of temperature, no tenderness felt over the both upper limbs, both lower limbs, no edema, Trendelenburg test one, whereas rapid filling from above while releasing the thumb, test 2 was positive. Whereas gradual filling of veins occurs below upwards in the mid thigh. Whereas in multiple tourniquets, filling of the veins at above and below the knee. Whereas in case of modified Perthes test, no increase in prominence of varicose veins. Schwartz test negative. Morsi cough impulse test was positive. Eagle test was positive. Button holding is present at the level of blowouts. Clinical picture showing peripheral pulses were palpable. No regional lymphadenopathy. Examination of right lower limb was normal. Systemic examination. Respiratory system was bilateral air entry was present. No added sounds. Previous examination, S1, S2 word, normal, no murmurs, abdomen, soft, non-tender, no organomegaly, palpable lump, normal bowel sounds present, external genitalia normal, rectal examination, no mass palpable, sphincter tone, normal, fecal staining present. My diagnosis, is a left lower limb primary varicose vein involving the left great saphenous vein due to an saphenofemoral incompetence of above and below knee perforators. Classification is C2. Etiologically, it's primary, and anatomically, it is involvement of superficial and perforator system, and pathologically, there is a reflux in the left lower limb.
Dr. Surya. Dr. Surya.
Yes, sir.
Yeah, let's go to your first slide on examination. Before that.
Dr. Hemant, can you please mute yourself?
Yeah, next slide, please. Dr. Surya, next slide. Yeah.
Yes, sir. Yes, sir.
You have to start off examination of lower limbs by comparison of the two limbs in the first.
Yes, sir.
Right? So
Yes,
you
sir.
have to compare the two limbs, two lower
Yes, sir.
limbs
Yes, sir.
on length, girth, the color of the skin, the integumentary system, all of them.
Yes, sir.
And then you have to come down to the affected limb.
Okay, sir.
Right?
Okay, sir.
Okay. So you've started with inspection attitude of both limbs normal. Then you go straight away. Are there any varicosities in the other limb?
Sir, no, sir.
Are there any varicosities in the right limb, lower limb?
Sir, no, sir. No varicosities in the right limb. Right limb was normal.
You have to clear that thing right in the upfront. Right?
Yes, sir.
Okay. So on inspection, there's nothing except other than dilated veins.
Yes, sir.
Right? You've seen Morrison's cuff impulse is positive on inspection.
Yes, sir.
Right. How will you distinguish? I say this thing is a femoral hernia. I say, what is this Morrison's cuff impulse?
Sir, when I ask the patient to cough, there is an expansible cough impulse can be felt at the saphenous opening, sir.
Right. Now I say that this is a femoral hernia. Prove me wrong. How will you differentiate between a saphenous bulge, right, and a femoral hernia?
So femoral hernia, it is a morely it can occur in females, sir. Whereas
it can't occur in male.
It can occur,
this
but
person, yeah, I say in this person, this is a femoral hernia with varicose veins. Now you tell me, prove me wrong.
Sir, where in case of femoral hernia, there is an expansile cough impulse in, sir.
There's expansile cough impulse here also.
It is here there is a progressive expansile cough impulse.
What do you mean progressive? Where is the femoral hernia situated?
Sir, it comes through the femoral canal.
Yes. So where is the femoral canal?
Sir, above the saphenous opening, where it will be in retort shape. Where there will be a narrow neck and it will come out through the saphenous opening.
Come on. Where is the femoral hernia? It's towards. How is it related to the pubic tubercle? It's very medial.
Yes.
Right?
Yes, sir.
You have the canal, vein, artery, nerve. So, and the canal. First the canal, then the vein, artery, nerve. Right?
Yes, sir.
That's medial.
It's more medial.
Also, what will it may contain gut?
Yes.
So you can get a gurgle.
Yes.
It may or may not be associated with varicose veins.
Yes.
Right?
Yes.
You get me?
Yes.
Yeah. So okay. So what is the first you've done this? Now, by your inspection, can you rule out arterial disease?
Sir, there is no loss of air, brittle nails, dryness of the skins,
Right.
or loss of subcutaneous
Skin
fat.
color is normal. The integumentary system is normal. There's no wasting of the limb.
Yes, sir.
Is the affected limb larger or larger than the other limb?
No, sir. No, sir.
Is the girth more?
No, sir.
Do you
Same
expect the girth to be more in a case of varicose veins?
case of
Okay,
varicose
suppose I
vein.
say the girth is much more in the affected limb than the other limb. What does that tell you in a case of varicose veins?
Sir, the patient develops any acute swelling like DVT. The patient develops swelling.
Yes, it shows that there's presence of DVT. Okay. Right. Now, next slide. Okay, if you have to do one test for varicose veins, which is the most important test?
Sir, I will do. Sir, to confirm, sir, to confirm varicose.
Oh, you've got this Brodie's Trendenberg 1 and 2. You've got this Perthes. You've got this Schwartz, Morris's, Fagans. Right? So which test do you do first?
Sir, I will do. If one test I will do, no, I will do modified Perthes test, sir.
Why? Very good. Why?
Sir, because it denotes whether the deep venous system is patent or not. It will rule out the
Right.
secondary.
Very good. So if the deep vein is involved, you can't do anything about it.
Yes, sir.
You can't proceed further.
Yes, sir.
Right?
Yes, sir.
So what is this modification? Modified Perthes test. What is Perthes test? What's the difference between the two? Modified and non-modified? Unmodified.
Sir, in case of Perthes test, where the elastic spark bandage is used, sir, to tie the lower limbs from the toes to the groin, so that we can't able to visualize the dilated veins, sir, when the patient walks.
Very good. Very good.
It is a
So
purely
okay, you've done the modified Perthes. Okay, that's fine. Now what is the next test which you will do?
Sir, after that I will do Brodie's Trendenberg test.
Right. So first you find out whether there's no DVT, right?
Yes. Yes,
Second, you find out whether the SFJ is competent or not.
Yes, sir. Yes, sir.
And that is by the
Brodie's Trendenberg one test, first test.
One. Then what is two?
Two for the perforator incompetence.
Right. It tells you whether two perforators are involved.
Yes.
And multiple tourniquet test is which perforator is involved.
Sir, below knee and above knee perforators are involved.
Yeah. All other tests are useless. They are just academic.
Sir,
right?
Yes, sir.
Okay. Now, you said this Morris's cuff impulse is positive. I think how does the stiffness vein enter the femoral vein?
Sir, through the defect in the cribriform fascia, it will.
Which fascia?
Cribriform fascia.
Cribriform fascia covers it. Covers that defect.
So defect in the deep fascia, it will enter the femoral vein.
What's the name of the fascia? Fascia lata.
Fascia lata.
Right.
Yes.
And
when you are doing the multiple tourniquet test, how many tourniquet you apply?
Sir, I will apply four, sir.
Okay. And how do you open that?
Sir, from below, we have to remove one by one, sir.
Yeah. From below, you know?
Yes.
That's the idea. Okay.
Yes,
Why we are not supposed to do surgery if we find DVT? In modified Perthes test, if we see DVT, we are not supposed to do surgery. Why?
Sir, if in case of DVT, the only draining system is a superficial venous system, sir. In case of if we ligate the superficial system, there is no draining of the lower limbs, sir. So that we don't do surgery in deep venous system thrombus, sir.
Okay, very good. buttonhole deformity is present. Where?
So
In the
it is,
superficial system or in the perforator system or in the deep venous system, where you find buttonhole deformities and how it is formed. In Fegan's test, you are finding buttonhole deformities. In your case, it is positive.
so it is seen in the perforator incompetence due to the defect in the deep fascia, where we can able to see the buttonholing over the deep fascia seen, sir. Felt.
Okay. In perforator incompetent sites.
Perforator
Very good.
incompetence.
Super. Good. Okay, go to the next slide. All the tests over. Previous slide. Previous slide. Previous one. Why you are looking after the peripheral pulses? It's a clear case of a varicose system, venous system. Why are you looking for the peripheral pulses? And which peripheral pulse you have felt?
Sir, I felt dorsalis pedis, sir.
And where you have felt?
Sir, it is for over the first and second between the first and second metatarsal, whereas it is lateral to the extensor hallucis tendon, sir.
Against which bone?
Sir, it is against an metacarpal bone, sir.
In how many percentage of people the dorsalis pedis will be absent in normal population?
Sir, less than 10%, sir. Don't.
Yes. 10% of the people will not have dorsalis pedis in that position. Okay, no regional lymphodenopathy, nobody. Examination of the right lower limb completely normal. Yes. Next slide. Organomegaly. Why you have looked for the any organomegaly in the abdomen?
Sir, if the patient present with a lower abdominal mass, any organs has been felt, it can be due to an fibroid uterus, where it can cause vein occlusion. Secondary varicose veins should be seen.
Okay. Slide. Next slide. So your diagnosis is left lower limb primary varicose veins.
Yes, sir. Primary varicose vein.
The left great saphenous vein due to saphenofemoral incompetence and incompetent
Above
and below limb perforation.
Should you measure the ABPI in these patients? Should you measure the ABPI in these patients?
Sir, no, sir.
Ideally, you should measure.
Yes, sir. Yes.
What is the ABPI?
Sir, it is an ankle brachial pressure index, where the pressure is measured in the ankle under the brachial system.
Yes.
Where ankle pressure system is a numerator, where brachial system is in the denominator, where the normal value is between 0.9 to 1.4, sir.
Okay. And if it is more than 1.4, what does that mean? And if it is less than 0.9, what does that mean?
If it is less than 0.9, it means the patient is going for an intermittent claudication ischemia and rest pain. If it is more than 1.4, it is due to calcified arteries.
So what is the significance in the venous disease of the ABPI?
Sir, in case of varicose veins, the primary management will be an elastic rub bandage, where we can apply after seeing an ABPA of more than 0.9. If it is less than 0.5, there will be an arterial disease also coexisting with that. So we should not apply an elastic rub bandage for varicose veins, sir.
ஆனது போயிட்டேன்ல
முடியட்டும் நீங்க
இதுல முடிஞ்சிடும் முடிய போகுது.
Dr. Arnachalam, could you please mute?
What
Yeah,
is
so it is because of the compression stocking which you are going to give.
Yes, sir.
No?
Yes.
So you should ideally measure the ABPI.
ABPs. Yes, sir.
Usually, how much pressure you give when you are giving the compression stocking?
So usually I will give pressure of about 30 to 40 mm of mercury, sir.
In which case?
In case of primary varicose veins, sir. It should be more in case of secondary varicose veins.
No, it depends upon the C category. Okay, if it is C1, 2 is there, then how much you give? If it is 3, 4 is there, how much you give? If 5, 6 is there, how much you give?
Sir, in case of it is 1 and 2, where I can give class 2 compression stocking, sir. In case of 3 and 4, where I can give class 3 compression stocking, sir. Where in case of 5 and 6, I can give class 4 compression stocking, sir.
Just remember 10 to 20, 20 to 30, 30 to 40, you know?
Yes.
Can you give the compression stocking even higher than 40 millimeter in any condition?
Sir, if the patient has an severe deep venous system reflux secondary varicose veins, where we can give compression pressure more than 40 mm of mercury, sir.
If the lymphedema is there, no?
Okay.
Okay, in the lymphedema case, you have to give the higher pressure here. Okay. So what are you going to do for this patient?
Sir, I will, in order to confirm my diagnosis and for doing surgery, I will do investigations, routine basic investigations and investigations like duplex ultrasound should be done, sir.
What do you understand by duplex?
Where the B mode ultrasound is combined with an Doppler ultrasound, sir.
Why you do that?
Sir, it shows an anatomical, physiological, and functional components of the veins, where reflex of the deep venous system is also seen, where the patency of the superficial system and the anatomical locations of the perforator incompetence and the GSV is better visualized, and other accessory veins also, which is seen in case of at the level of GSV, and reflex also measured in the saphenofemoral junction.
How much is the positive reflux at the saphenofemoral junction? When do you say that?
So, in case of saphenofemoral junction, the positive reflex is more than 500 milliseconds, sir.
And when do you say the perforator incompetence is there?
Sir, in case of perforator incompetence, it is more than 350 milliseconds, sir.
Anything else which is added to that, apart from the 350 millimeters? 350.
3.5 mm defect, sir.
Yeah, defect of the 3.5 mm. Yeah, that's right. Where do you usually measure the saphenous vein? What is the usual site of telling that GSV is dilated at what point?
Sir, it is usually measured at the mid-thigh level, sir.
Good, at the mid-thigh level. Yeah. Okay.
What if
Now,
saphenous eye in the ultrasonogram? Saphenous eye. Have you ever heard of that terminology?
Sir,
Surya.
in case of B mode ultrasound, we are seeing in the saphenous at the saphenofemoral junction, we can see the saphenous deep to the saphenous fascia. The saphenous vein will show us on saphenous eye, sir.
What is
it
Mickey
is
Mouse
also
sign?
called Egyptian eye, no?
Egyptian.
eye.
Egyptian eye, yeah.
What is Mickey Mouse sign?
Sir, at the saphenofemoral junction, where we can able to see the three structures of the artery vein as in Mickey Mouse, where GSV drains into the common femoral vein and the femoral artery forms the Mickey Mouse signs.
Good, good. What do you mean by SEEP classification? What represents CEAP? Quick.
Sir, C is in clinical, sir. It is a one. There is a telangiectatic veins, where 2 is an varicose veins, where C3 is an edema, where C4A is an pigmentation or eczema, where C4B is an lipodermatosclerosis or atrophic blanche, where C4C is an coronaphlebitis, where C5 it is an yield ulcer, where C6 is an active ulcers, where it has a additional symptomatic or asymptomatic, sir. And in case of E, it is an etiological classification, where it is due to congenital cause. EC is a congenital, EP is a primary, ES is a secondary, or EN is a no identifiable cause. whereas in case of anatomical, where it is in a superficial system, or it can be in deep system, or in case of perforator, or in case of pathology, where there is a reflex, or in case of obstruction, or reflex plus obstruction, or no identifiable pathology can be identified.
Very good, fantastic.
What is the significance of C4C?
Sir, if the patient has a C4C coronaphlebectasia, the patient is gradually impending to development of ulcer, sir.
C4C initially was in the C1, in the older classification, the C classification. But then it was found that if there's a C4C, the ankle flare is there, they are very likely to have the venous ulcer.
Yes.
So that is why it was shifted from C1 to C4C.
Yes.
What are the two signs related to DVT? How will you elicit DVT?
Sir, the two signs are, one is Oman signs and Moses signs, where in case of Oman sign, where there is an forceful dorsiflexion along with the extension of the knee causes severe calf pains.
Sudden dorsiflexion of the foot,
Sudden dorsiflexion
isn't
of the
it?
knee.
Yes.
Yes. In case of
Yes.
Moses sign, where compressing of the calf side to side, where causes severe pain.
Squeezing of the calf muscles. Yes.
Squeezing.
What is the complication of that Moses sign? Eliciting Moses sign.
Sir, it will discharge the thrombus into an pulmonary, and it will cause pulmonary embolisms.
Pulmonary embolisms. Okay, how do you manage this patient? All the investigations over. Do you play study everything?
Yes.
Are you going to do surgery or sclerotherapy? What you are going to do? How will you manage? Surya.
For saphenofemoral incompetence, I will go proceed with an surgery, where I will do Trendelenburg procedure, which is an saphenofemoral flush ligation, along with the stripping of the GSV should be done, sir.
Up to what level? Stripping of the great saphenous vein.
Just below the knee, sir.
Why?
Sir,
up to that level.
After below knee, the GSV is closely related to the saphenous nerve. So it is ideal to remove up to below knee, sir.
Okay, what if the flush ligation? Why can't you leave behind some stump in the great saphenous vein?
Sir,
what is it?
Sir, it will cause a recurrence, so that we have to ligate it close to the femoral veins. Saphenous vein should be ligated close to the femoral veins.
Okay, where will you put the incision for Trendelenburg surgery, flush ligation?
Sir, I will put two finger breadth below the groin crease. I will put a transverse incision over the medial side of the thigh, sir.
Okay, you are doing Trendelenburg surgery for that. Trendelenburg 1 is positive. Any other?
Sir, for and the stripping of the vein should be done, sir.
Okay. Why are you stripping? Is it necessary in this particular patient?
Sir, stripping can prevent recurrence more when compared to not stripping, sir.
What are the complications of stripping of the vein?
Sir, it will cause nerve pain, neuritis, skin bruises.
Yes. What are the indications for sclerotherapy?
Sir, sclerotherapy is done in dilated veins which is less than 3 mm in diameter, where recurrent varicose veins.
Okay, tell me some 2 or 3 sclerosants that you know of.
Sir, sodium tetrahedral sulfate and sodium polydocanol.
Ethanolamine oleate.
Ethanolamine oleate.
Okay, what is the recent advance of managing this varicose veins?
Sir, recently endovenous laser ablation and radio frequency ablations are developed.
What amount of heat is necessary or produced in radio frequency ablation, RFA?
Sir, sorry, sir.
How much amount of heat is produced?
Sir,
In
in
radio
case of
frequency-
radio frequency ablation, 120 joules per
120
centimeter.
joules. In laser, only joules. Here in radio frequency ablation, 120 degree.
120-degree heat is thermal energy is produced to ablate the veins. Sir.
What are the complications of RFA?
Sir, the case of complications of RFA, where recurrence will be there, sir. If it is very large veins, where recurrence will be there, sir. Skin bruising will be seen, or when we ablate close to the femoral vein, it will cause a deep vein thrombosis.
Skin burns.
Skin burn.
How will you avoid skin burns? How will you prevent?
Sir, by using tumescent injection around the veins.
What are the components of tumescent fluid?
Where in case of tumescent, where we use 450 ml of ringer lactate along with 30 ml of lignocaine and 16 ml of sodium bicarbonate with 1 ml of adrenaline used, sir.
What do you mean by EVLA?
Yes, sir.
EVLA, endovascular laser ablation.
Sir, here diode laser is used to used to ablating the veins, sir. Here the laser of wavelength of about 1470 nanometer wavelength of light is used to produce 60 to 80 joules per centimeter has been produced, and we can gradually displace and then we can ablate the veins, sir.
Okay, what do you mean foam sclerotherapy?
Sir, in case of foam sclerotherapy, where 1 ml of sclerosant agent mixed with 3 ml of air using a 3-way valve and 2 syringes, where we can able to mix it for 20 times, and within 2 minutes the sclerosant agent is introduced into the veins. After emptying the veins, where the sclerosant agent is introduced into the veins, which cause an aseptic sclerosis of the veins.
What is the advantage of adding air with the sclerosing agent? Making foam.
Sir, so that a small amount of sclerosant agent can be used for larger surface area, where it will not allow the blood to mix with the sclerosant agent, and it will cause inactive of the sclerosant agent. And less amount of sclerosant agent can be used in case of RS mixed.
What is that method called as?
The method is called as Tessera's method, sir.
Sorry. Okay, which laser is used for the varicose veins?
Sir?
Which laser is used for the varicose veins?
Sir, diode laser is used for.
Diode, yeah. Okay.
Diodes.
Yeah. Can you use any other laser for the varicose veins?
Sir, CO2 laser, sir. NDA.
It is NDA can be used. NDA can be used. And NDA is usually for which type of the varicose veins?
Primary varicose veins.
Yeah, primary, but C1 category.
C1 category.
Okay, C2 category, you have to use a diode. Okay,
Diodes.
Have you heard about the CLACS? What is CLACS? CLACS? Which is used for the spider veins or the reticular veins. It's a type of the sclerotherapy.
No, sir.
Okay. It is called a cryolaser and cryoablation. CLACS. Cryolaser and cryoablation sclerotherapy. Okay, where you use the laser combined with the sclerotherapy.
Okay.
Okay, Surya, last question from my side. Why in the upper limbs, the varicose veins are very rare when compared to the lower limbs? Have you ever seen a varicose vein in the upper limb in your Madurai Medical College? in your Professor Saravanan sir's unit? No, why?
Sir, lower limbs are more common because of the gravity. We have more in the lower limbs, where upper limbs are rare.
It's very close to the heart, isn't it?
Yes, sir.
Yes. Usually, so it is in the upper limbs, it's very rare. Okay?
Right.
Right.
But if it occurs, then what is the cause for that in the upper limb?
Sir, it can occur due to an AV fistula.
Yes. So they are mostly secondary,
Secondaries.
either because the axillary vein thrombosis. Okay,
I-
sometimes the badminton players and the lawn tennis players, they can develop the thrombosis of the axillary vein. And secondary to that, you can have the varicose veins of the, or if there is thoracic outlet syndrome is there,
Yes,
you can have the secondary
varicose.
varicose veins. So majority of the time, they are the secondary varicose veins in the upper limb.
Okay.
Hello, Dr. Surya.
Yes, sir.
In the foam sclerotherapy, you said it is less volume is required, right? One thing is that.
Yes.
What are the other more important factors? Why a foam is made instead of just putting a liquid sclerosing agent into the vein?
Sir, in case when sclerosing agent is admixed with blood, it can get inactivated, sir. In case of where sclerosing agent with added with an air, where it displaces the blood and will prevent it from inactivation of sclerosing, sir.
No, don't get inactivated. It displaces
Surface
the
area.
blood, one thing. It comes in contact with the wall better than the just liquid. And during the procedure, ultrasound visibility is better when the foam is entered into the vein as compared to the liquid, right? And obviously, less volume is required. How the components of the tumescent anesthesia work when you do endovascular treatments?
Sir, components are ringer lactate, sir. 450 ml of ringer lactate.
Usually normal saline is used, not ringlet. Then what
Yes,
is
sir.
another components used? So how it helps? How these three things, a mixture of
So
three things, that is normal saline, lidocaine, and
it
adrenaline.
acts as an heat sink where it displaces the nerve and it compresses the veins and it also
Displaces the nerve. Please reframe your sentence.
um, where it will prevent it will displace local
One is
anesthetic
local pain relief. Second is
and it will prevent the thermal burns.
how?
Sorry, it acts as an heat sink where the tumescent agents will prevent burns injury to the
Because
skin.
one relative contraindication, it should be avoided in superficial dilated veins. It should be at least more than 5 millimeters below the skin or subfacial, right? So it acts as a fluid heat sink between the skin and the vein, because the only complication which is more in endovascular procedure as compared to the open surgical procedure is the cellulitis and dermatitis which happens. That is a very frequent complications in, and the post-operative pain is also more due to the dermatitis, severe dermatitis, right? Otherwise, they are less invasive procedures are now preferred over the surgical procedure, right? You said in the duplex scan for peripheral arterial disease when you're suspecting. What is the inference of the monophasic, biphasic, triphasic, and how it is produced?
Sir, in case of a normal artery, there will be an triphasic flow, sir. When it get calcified or atherosclerosis, it will become an biphasic or monophasic flow will be seen.
To what physiological component it corresponds? What are the three phases of the waveform? And in biphasic, which one is absent?
Sir, in case of biphasic, the early
First, tell me
diastolic.
how these three, what are the three waveforms?
Sir,
How they are produced?
systolic, early diastole and late diastolic, sir.
Yeah. So which one is earliest to go in most of the cases?
Early diastolic will be absent in most of the.
No, late diastolic.
Late diastolic will be absent.
Late diastolic goes first. Though it can be different in some patients, but usually that is not. Right. Thank you.
Can you use endovenous glue,
Yes, sir. Yes, sir.
Surya?
Yes, sir. We can
What
use
is the name of
endovenous.
that glue? What is the name of that glue?
Sir, cyanoacrylate glue can be used.
Acrylate. Okay, okay. What is the disadvantage or side effect of that using that glue?
Sir, it is very costly, sir.
Hmm.
And it can cause allergic reactions.
Hmm.
And it will cause us recurrence, sir, mostly. This one.
It will look like a cord-like structures after this procedure. Okay. Okay.
Do you know any other thermal type of the endo treatments apart from the laser and the RFA?
Sir, high frequency ultrasound, sir.
That is what's called a HIFU. You know, HIFU is
HIFU.
especially it is not a thermal one. You know? It is in fact supposed to be absolutely non-invasive variety. The thermal, you can use the laser, you can use the RFA, you can use the steam. Okay, and you can also use the microwave. Okay, so these are the 4 types of the thermal treatments.
Okay,
and non-thermal treatments are the sclerotherapy,
endovenous glue, and mechanochemical ablations.
Yeah, what's called a MOCA, you know? MOCA treatment for that. So these are 3 types of the non-thermal treatments.
Okay.
You know, when you are doing the laser treatment, have you ever seen the laser? Being done? No, you're not. Okay, then it's okay.
What is the length of the probe in a radio frequency ablation? Have you ever seen in Madurai Medical College being done? It's being done. Radio frequency ablation in.
No, it is done, sir, but I have not seen. It is done.
You have to go to the
length is
vascular
7.
department.
Length
good.
is 7 centimeters.
Very good, fantastic. 7 centimeter probe. Okay, in radio frequency ablation. You answered almost 85 to 90% of questions, Surya.
Yes, sir.
Fantastic. Good, good. Okay, any other questions from Professor side? It's already 10:35.
Thank you. I think we should finish up. Great.
Dr. Surya, do you have any doubts to be clarified?
Sir, no, sir.
Thank you, Surya. Thank you for accepting this case, especially only after yesterday evening you collected the case and prepared well. Good luck to you. Thanks to Ganga ma'am and Saravanan sir for permitting you to this case.
Yes, sir.
Hemant sir, thank you very much for staying back so late. And thank you for permitting Dr. Siddhant to present the case of Acahalasia. Prabhakar sir, Gupta sir, Kandan sir, Rajiv Sakai sir, Kirit sir and others who have stayed back. Thank you very much, sir. Next week, we will meet with another with next case. Thank you very much. Good night, everyone.
Good night. Good night, everyone.
Thank you. Thank you.